This patient we did long back upper rehabilitation. Not full mouth but premolar to molar. More than 8 years back, she is still living with that denture. In the meantime, many teeth in the lower jaw they got removed. She is selling flower near our clinic. Okay. Now we are going for full mouth here. 1, 2, 3, 4, 5, 6 and almost 7 implants from premolar to molar. Now we are going to place additional implant in the upper and lower full arch. Okay, we will see the simplicity now.
She will pay for this, sir?
No, we are doing without any charges. The treatment also we did lower than a First we'll plant the lower jaw. So lower jaw, how will you plant? Interforamina 4, distal mandible 2R1, distal mandible 2R1. Okay. So how much bone above the canal determines whether it is a simple, advanced or complex. Here there is a lot of good bone is there. Anteriorly also some decent bone is there. So it is a straightforward situation, simple situation. Some bone leveling needs to be done. Wherever tooth is present, see there is a resorption here and some bone is there. Here the bone level is at a higher level, here it is going down. Here it is at higher level. So after extraction, don't place implant immediately. Better to open the flap, level it, remove this poor alveolar bone because they will resorb in future this kind of bone. And also we will see everything openly also. If you can expose the mental foramen, we can avoid injury to the mental foramen also. So the planning wise, we already discussed yesterday. First premolar one, here first premolar one, lateral incisor. So this is the molar area, right? So always whenever there is a tooth is there, this area is a better right place to start the drilling, this crest. So here one implant we can place, this distal to here, we can place one implant here. Here, either the distal root of 6 or in the interdental bone, we can place one. Other implant can be placed either here or either interdental bone. We have seen the lingual island yesterday. Lingually there is an island. So we can always use that island in the premolar area. So the canal we can see a little bit, but here it is reducing. This is the mental foramen. This is the mental foramen. So do we need to see the CPCT? This case, no, not very much, because anyhow you are going to open the flap. If you have a good stock, then you can manage this. If there is a labial defect here, then you have to place a BCS. If buccolingual bone is good after alveoplasty, you can place a compressive. So only thing you have to decide is how much length you are going to place here, which is right. Here we cannot decide the length during the surgery. Decide the length before the surgery. So if you don't have CPCT, how will you compensate this? Take a IUPA. Don't measure in pano. In pano, that magnification error will be there. So take IUPA and you can measure. Only 8, 10 or 12 around 0.5 is enough. Okay, 10 is more than enough. Okay, mostly we can place at 10. The nerve is very
regularly. Without resorption, posterior
10 is enough. 10.
Anteriorly, you can go for 9.
Anteriorly, resistance. Resistance will determine your length.
Usually other length.
So sometimes only 10 will be enough. Sometimes you can place up to 14 or 16. There is no fixed one. So if you are doing very minimal alveoloplasty, then longer one. If you are doing, and anterior mandibular height varies from patient to patient also. And this anatomy also varies, C shape, tubular shape. So various factors determine the depth here. Here if you are planning for intramedullary, it will be around 8, 10, around 10.
In the anterior, the orientation also, like whether to go straight or little bit lingual or...
Yeah, keep finger on the lingual side. Follow the lingual. Lingual.
Lingual and hip
Yes. So that is this called finger bracing technique. One finger on the lingual, one finger on the buccal, so that your drill doesn't go to buccal or to lingual. So first we will see the mental foramen. Even the mental foramen area is ideal. If the other areas are not good, you can plan for this ventral foramen area implant also. But anyhow, we are going to place in the first premolar. Almost parallel, right? A small curvature here is there, but anyhow we will do alveoloplasty. So stay close to the lingual cortex and we can place the implant. We can place compressive also. Bone width is there. You can place a 3.7 mm. 10 mm long point we can place. So this projection now, this can help us to find the midline. Otherwise, sometimes wrongly we will place the implant in the midline and then we have difficulty in placing this implant. So after opening the flap, we may lose orientation. So we have to keep an eye on the midline. So here it looks somewhat tricky. It's knife edge. Without doing shaving this crestal bone, it is difficult to do drilling. It may slip either here or it may slip in here. If you try flapless, mostly we will slip. So better open the flap and do a minimal alveoloplasty. Then we can place it. The width is very less. We will select a smaller diameter implant, 3.5, or we can place a BCS basal. Right? If you place BCS like this, it will get support from the buccal and BCS also you can, basal also you can try here. So if you are placing basal, it will be around 3.614 or something. So both implants are possible. Here also the same plan, either smaller diameter, compressive, or placing basal. It will get good stability from engaging this, and in this bone also is good. And this is the area of the bone defect. So there is a small periapical lesion is there. So if our implant comes in this area, then better to use a basal design, because this bone will go, there will be a lot of infection there. So we place implant in the first premolar. So crustally the width is less, but once we shave the crustal bone, we will get a good 3.75 or 3.5 we can use. It's good for compressive implant. A slight mesial tilt to avoid the ventral loop. There is a distal decay in seven loop. So this is the mesial crest of the seven. Always the bone quality here will be good. Wherever there is a natural tooth and you are extracting it, you can use it. 10 mm is will be okay. 4.2 into 10. If you see here, the bone is very much cancellous. We don't know which one is the canal. Mostly this may be the, this is more darker. So the more CBCT we see, we will come to know. So to find out whether this is the canal, we will keep the implant just above that suspected area. Here you can find out. Mostly that will be the canal. So that means it is around 12 mm. We can place 10 mm implant. 4.2 into 10 we can place.
Minor head itching there also.
Yes, that is a case actually for that. We can try like this also. Yes. We can use actually longer implant. 4 into 12 we can use. So what we will do is we will do lingual cortical here. If we do lingual cortical engagement, only 3 implant is enough for that side because you are getting good stability. And inter-implant distance is also better here. But here if you see, the inter-implant distance is more. So better to place one. Or there is one more technique to reduce the inter-implant distance without adding implant. This implant we can tilt. And start from 5. Tilt more easily. So in this way, so if you start the implant from 5 and tilt, we can reduce this inter-implant distance and you can manage the situation with all on 6. So whenever you are tilting, the most important question is whether the bone quality is quite decent. Otherwise, while bending, the implant won't bend, the implant will move through the bone. So this patient we will do tilting and all on 6. Okay. So there is a surgical technique to do the proper tilting because placing axially is very easy. Select 4 and place straight with slight mesial tilt if you want to with slight mesial tilt. But when you are starting from 5, you are angulating. So how much angulation we have to give? Where to start? These 2 factors will come into play. Whether to start from here or here or here. So where to start and how much mesial tilt we have to give. There is some surgical tips are there. If we follow that, we can avoid nerve issues. So what you have to do is you have to locate the mental foramen first. In front of the mental foramen, 5 mm away from the mental foramen, you mark a point. Okay. Above the mental foramen, you mark a point. So you have to connect this point with the drilling in front of the point. Okay. So if you do like that, you can avoid mental lodging. So what is the scientific base? This is based on the scientific fact that the mental foramen can extend anterior to also as a loop. Right? So the loop maximum it will go 5 mm. So you draw 5 mm above it and do the drilling in front of the marking. Okay. Start from there. So during this drilling also you have to respect the resistance, otherwise we may perforate labially or the inferior border. So we will so this is in front of 7. This is a canal around long point facial. We can place a 10 mm implant very easily. There is some ready opacity is there, some good bone. Otherwise, we can go for a lingual cortical also. That is also one option. But we will place a crestal one this side. Left side we will place a lingual cortical. Both sides we will do the tilting. So you know that is a nerve and some anterior loop is coming. Right? This is a nerve, this is a foramen, this is a loop. This is the anterior loop. So that is why we need to tilt it. So if we do like this, 6 implant is enough. We have done many cases with 6. But why we avoid 6? Tilting requires mental skill. We have to see it and do it properly. This is more simpler plan. Shak, 8 implants. Less brain is needed. But here you need more, you have to you have to mark with pencil, then drilling also you have to do carefully. But we will do this for the patient.